everyone. Welcome to the Maternal Mental Health Webinar. We are so excited to have you, and we are going to kick this off with our guest speakers and our host in just a minute or two. We want to make sure everybody is able to get in to the Zoom room and get comfortable, be excited, and we'll get started in just a moment or two. All right. I will keep letting people in as they join, but I want to value the time of our guest speakers as well as our guests that have registered tonight. So I'm going to go ahead and get started. My name is Donnell DeRubis. I am one of the CalHOPE peer support specialists with NAMI Greater Los Angeles County, and I will be the behind the scenes working with you tonight. If you have any questions throughout the evening, please drop that into the chat and we will make sure that we address that. Before we get started, I do want to find out, because we are blessed to have a Spanish translator with us tonight. So if any of you are in need of Spanish translation, if you can raise your hand, even if you want to come off mute real quick just to let me know, yes, you need Spanish translation, that would be great. I will scroll through and see if anybody's raising their hand. So we do have a Spanish translator. You can also drop it in chat if you want to let me know that you need Spanish translation, and then I will go through those instructions with you. Okay, I don't see anybody, but please know that she will be with us throughout the evening. So as we get started, if you find that you would like the Spanish translation, again, just reach out to me in chat and I will let you know exactly how to do that. It's super easy. If I could figure it out, I promise you'll be able to figure it out. So let's go ahead and kick off. I'm going to share my screen real quick. Hopefully you all can see that. So you are here tonight for the Maternal Mental Health Webinar. This is a part of NAMI, the Greater Los Angeles chapter, and brought to you by the CalHOPE team, our amazing supervisor, Lagaya, who will introduce herself. Again, we do have the Spanish translation, so if you need that this evening, please do not hesitate to let me know in chat, and I will get you all set up. But real quick, I just want to go through some of those webinar guidelines. I know we've probably all been on Zoom a million times. First and foremost, please know that this is a safe and respectful and confidential space. The webinar, as I mentioned in the very beginning, is being recorded. Your camera can be on or off. We would love to see your face, of course, but please do what you feel most comfortable with. I am going to ask that everybody stays on mute tonight to help eliminate the background noise and distractions. And we will have a Q&A session at the end. So again, please drop any of your questions into the chat. It can come to either myself or my co-host on the Zoom, Lagaya, and we will make sure that we get those addressed this evening before the night ends. If for some reason we can't get to all of the questions, again, we have your contact information, so we'll make sure we follow up with you. For those of you who don't know who NAMI is, we are the National Alliance on Mental Illness, and specifically, you have joined the Greater Los Angeles chapter. We are an affiliate of a countrywide nonprofit organization, of course, located in Los Angeles County. We support mental health for those affected and the community, so families and peers alike. Tons and tons of advocacy work, education, support groups, and we really just want to emphasize that mental illness is treatable and people can live fulfilling lives. As the Greater Los Angeles chapter, we have several affiliates or chapters that kind of support the Greater Los Angeles area. So pretty much wherever you live, you are going to find a chapter that supports your specific area with support groups. We have family to family. So if you want to learn how to support a loved one, that would be a great program for you. Peer to peer, anybody 18 and over who might be struggling with a mental health condition. We have educational classes. And of course, we have our webinars. So all of our programs are free to the community, and they really are a great way to get support, to feel empowered, and really become a part of a community that just embraces everyone. We have tons of resources, and I know firsthand that sometimes it can feel overwhelming. Where do you even begin? You begin with NAMI Greater Los Angeles chapter, and we've got you. We'll help you out. You can find out more about who we are and the various programs, again, including those support groups and educational classes that we offer by visiting our website, namiglac.org, namiglac.org. So without further ado, I'm going to turn it over to my amazing supervisor, Lagaya, and she will kick us off for the evening.
Hi, everybody, and welcome to the NAMI GLAC Maternal Mental Health Webinar. We are so excited to have you. This topic is a topic that is much needed discussion around, and we have a great panel here for you. I don't want to take too much time introducing myself, but I'm Lagaya Sevilla, and I am the CalHOPE team supervisor of 6 amazing peer support specialists. We run a warm line that is open 7 days a week, and we also do outreach in the local community, providing NAMI resources to those with mental health conditions and those who support their family members and friends with mental health conditions. And we've recently launched this webinar series on various topics. May is Maternal Mental Health Awareness Month, and so we're very excited to talk about this. This has personally affected me when I had my daughter 3 years ago in the middle of the pandemic in 2020. I suffered with severe postpartum anxiety and OCD, which we will get into. And ever since then, it changed my life, frankly. And I pivoted from a career in corporate entertainment to a career in mental health. And now I work very happily for NAMI GLAC and as the CalHOPE supervisor. So we have a lot to get into. So let me just first introduce our amazing panel. First, we have Dr. Eynav Accortt. She is a clinical psychologist and research scientist. She is the director of the Reproductive Psychology program at Cedars-Sinai. So welcome, Dr. Accortt. We have Dr. Sinmi Bamgbose, who is a reproductive psychiatrist at Cedars-Sinai and in private practice, and is passionate about the complex relationship between hormones and mental health. She is a member of the Maternal Mental Health Now Black Birth Workers Advisory Council. So welcome, Dr. Bamgbose. And last but not least, we have Anita Burdette, LCSW rather. She's a licensed clinical supervisor at Watts Healthcare Medical Center. She is passionate about providing access to resources and therapeutic interventions. Anita primarily works with the Black and Latinx communities. So we've got a lot to talk about today. We're very excited to get started. But before we begin, just as Donnell said, I want to remind everybody, if you have a question, go ahead and drop it into the chat. I will devote the last 20 minutes to Q&A, and we will get to as many of those questions as we can. And if we don't get to your question, we will more than likely email you back an answer in our blast email that we send to everybody after this is complete. So do ask any questions you have. So with that, let's begin. My first question is for Dr. Accortt. Please tell us about perinatal mood and anxiety disorder, aka PMADS. What are they, and what are the symptoms and risk factors during pregnancy or after birth?
So thank you so much, Lagaya and Donnell and NAMI, for having us today. I'm really happy to be here. So excited to see this topic being highlighted, particularly in Maternal Mental Health Awareness Month. So important. And I have been interested in women's mental health more broadly for my entire career. But in the past 10, 15 years, I've really focused on PMADS, perinatal mood and anxiety disorders. And when I entered the field, specifically perinatal mental health, everyone only talked about postpartum depression. That's all you ever heard about. And many of you on the call who are my age or older might know exactly what I'm talking about. We just hear people talk about postpartum this, postpartum, but postpartum is really just a moment of time, right? It's just depending on the descriptor, wherever you're reading it, it could be up to 6 weeks postpartum, 3 months postpartum, 6 months or 1 year postpartum. But perinatal, that piece of the term is critically important because what that means is these illnesses, these symptoms, I should say, can and often do begin during pregnancy. So perinatal, that term, includes the entire pregnancy as well as up to 1 year postpartum. So when we talk about perinatal mood and anxiety disorders, we're talking about a range of mental health conditions. So it can include major depressive disorder, generalized anxiety disorder, obsessive compulsive disorder, as you already mentioned, Lagaya, panic disorder, post-traumatic stress disorder. Any of these conditions can begin during pregnancy or up to 1 year postpartum. And it can be very challenging for someone who's distressed to really identify their need for intervention and treatment. And so even if you are not a birthing person, it's so great to see all kinds of folks on this call because family members and friends can really look out for red flags. The issue for the birthing person is they're likely exhausted, either in their pregnancy or caring for a newborn, as well as for themselves. So I would say the main red flag that I will tell my patients, but also family members and friends to look out for is if someone is acting differently, what is really unusual for them, and that whatever the symptoms may be are causing interference in their functioning. So they used to be able to go out and have lunch with a friend. Now they don't want to leave the house, right? So it's something where there's absolutely a change in the functioning. And you asked about risk factors. I'll say probably the biggest or number one risk factor is having a personal or family history of depression or anxiety. That's a very critical risk factor, but it isn't the only one. So the way I encourage people to consider risk factors for PNADs, but quite frankly, for any mental illness, is to think about it from a biopsychosocial perspective. So by bio, I am talking about all kinds of things. It could be a genetic risk, right? So maybe, like I said, you or your family member has mental illness. Maybe there were medical complications during pregnancy, during delivery, after, right? Maybe that led to increased inflammation. So there are certain biological things that we can't always have any control over. For example, being very young when you're pregnant or postpartum, or quite older, when you're pregnant or postpartum. Those are biological risk factors. What about the psychological piece? So stress. Stress is a major risk factor. And so I like to think about the sort of extreme example is if you have a pregnancy complication or a baby in the NICU, right? You're going to be very stressed. You're going to be very concerned about your health and or the health of your baby. So that's going to put you at psychological risk, right? And then there's the social piece. So like I said, it's biopsychosocial risk factors. So the last one is, and as important as the others, is the social risks. And we know that women of color experience discrimination and racism, and that is a risk factor for perinatal mood and anxiety disorders. So I think it's important that we always kind of view all of these conditions from those multiple ways of thinking. There's never, or rarely, a single cause explanation for PNADs. And I also like to think about this in a positive way. You may have a biological predisposition, right, for a PNAD. Maybe your mother had postpartum depression. Okay, but you may never develop the condition because perhaps you really focus on minimizing your psychological and social stressors, right? So I kind of try to think about this in a unique way, and it's not all doom and gloom. Because people ask me about risk factors, and it does kind of feel heavy. So thanks. I'm hoping that if you guys have any additional questions, I'm happy to answer those as we move forward.
Thank you, Dr. Accortt. Next question is for Dr. Bamgbose. How do we know when PMADs are advancing into a true psychiatric emergency? What are the warning signs that moms and their families should be looking out for?
Thank you, Lagaya. I think it is really great to be here with everyone talking about this topic. And I think Dr. Accortt touched on it a little bit too, in terms of what we're looking at when we're talking about what are the symptoms. So if we're talking about postpartum depression, we think about, is somebody so depressed they're not bathing, they're not wanting to eat, they're not wanting to spend time with their baby or their family members, they just can't get out of bed. So those are pretty severe symptoms of depression we want to be looking out for. On the other hand, something like anxiety, if they're so worried in terms of those obsessive compulsive symptoms where they're thinking, okay, what if my baby stops breathing tonight, and they just stand there all night watching their baby sleep, or, if they think if they move, something's going to happen. So things like that, where we start to really, as Dr. Accortt said, worry about the functioning of this person. And then, so those are times when we say, get a therapist, get a support group, have some other people to talk to, and start using those resources that are available to you if we can find them, right? Which we'll talk about later, how we get to find these resources. But when it's a true emergency is when we really think of really scary potential outcomes. So if the mother or birthing a person is starting to have thoughts of not wanting to live anymore, feeling like they're a burden on their family and everyone would be better off without them, that's an emergency, definitely, because we know that, unfortunately, maternal suicide is one of the leading causes of postpartum death in this country. So we have to think about that. If they have thoughts of hurting the baby or anyone else, that's also an emergency. So I think at that point, when it becomes so debilitating that we're worried about their own safety or someone else's safety, that's a true emergency there.
Thank you, Dr. Bamgbose. Our next question is for Anita. I've heard you mention safety plans during our discussions. What does a safety plan look like, and do you work with new moms to establish these?
Hi, everyone. So yes, the piggyback, what was already mentioned, a safety plan is such a valuable tool. It eliminates a lot of safety concerns for the mother, unborn child, or if the child, like we said, within the first year. So the first thing that usually we sit down with a patient, and it would be the clinician, therapist, and after assessing what mental concerns that are displayed, a safety plan is a great way to be able to add that extra buffer of resources. So on the safety plan, pretty much we mention warning signs, as such as mentioned. Warning signs triggers. It's good for the mom to know what exactly is going on, when is alerted, when we should look at the rest of the safety plan, which we move into. If we pay attention to that, we go to the next stage of coping. What coping skills does she have? What strengths does she have? And what are the tools she can use? So a list is built off of that. And from that list, we also gather phone numbers of friends, families, and professionals, and 988 and the warm hotline. Anyone that could be of value to the mother, because this is a buffer just in case she can't get any other resources. She could place this on her refrigerator. She could have it in her phone. It's something that she can immediately get to. And then from there, we also look at, who can she call if she needs childcare? What are your childcare options? Because we have to think of the safety of the child. If there are any other children, if the child is under one. So on this list, we also add, who can she reach out for childcare? So this whole list is completed. A copy is given to our patient. We keep a copy for the patient. We go over it, and during follow-up sessions, we also update it. We add to it. We talk about it, and we actually, use the resources when it pertains to coping and self-care. So that's pretty much how it's implemented with our patients here at WAS.
Thank you, Anita. Next question is for Dr. Accortt. How are we currently screening for PMADs, and what should new moms know to prioritize to help avoid postpartum conditions?
Yeah, this is a critically important question. So I'm really glad that you brought this up. I think that more and more states are adopting actual bills and legal requirements to do what we call universal mental health screening. But we can't just stop at screening, right? So just asking questions about a person's symptoms isn't enough. In fact, doing just that could even be seen as unethical because we don't just ask about the problem, right? So it really needs to be encouraging birthing hospitals, for example, to do universal mental health screening with reliable and validated screening tools. For example, the Edinburgh Postnatal Depression Scale is one that's commonly used. The Patient Health Questionnaire is another one, and there are others, right? So there's never necessarily a right, wrong, or better or best. It's just a matter of not asking, are you feeling depressed? And that being the only question. But that's not appropriate. So we want to use a reliable and validated screening tool. And we can't just stop there. We want to educate. We want to make sure individuals are made aware about the symptoms and things that Dr. Bamgbose and Anita have already talked about so that they may not have the symptoms right then and there when we screen them, right? So what's recommended is screening in the pregnancy. Some groups actually recommend screening every trimester, and I support that. I think that's really ideal, right? Because your mood changes a lot throughout the pregnancy. But let's say we screen someone only once during the pregnancy and they don't really have very many symptoms. Well, you've really missed a huge opportunity if you don't take that time to educate them. Hey, these are some things that could come up for you. We're so glad you're not experiencing them now, but they're relatively common. We want to tell you the difference between, say, baby blues and postpartum depression, which I think we'll talk about in a few minutes as well. But we want to educate so that they can kind of keep their eye out, have their spouse keep their eye out, right? And then we also want to do effective referrals. So Anita has already started to talk about that. I think it's important when we're doing universal screening. And what I mean by that, so that term, universal screening, it means that we don't just select based on our clinical intuition. Oh, that mom seems sad, or oh, that mom seems stressed, so I'm going to ask her some questions. That doesn't work. We have learned now that that absolutely doesn't work. Some people are really good at putting on what you kind of call a mask. I'm fine. I'm good, right? But inside, they're really struggling. So we don't want to single anybody out. And that kind of leads me to my next piece, which is what's critically important for effective screening is that your staff is trained. We want to make sure that staff, that nurses or social workers, whoever it is that's doing the screening, is understanding, is non-judgmental, is asking these questions in a way that's really caring. For example, even just switching the framing. So coming into the room and saying, oh, we at Cedars, this is, what we say, we at Cedars are committed to family wellness. And so that's how they start the conversation about screening. It's not, I'm here for postpartum depression. That just makes it sound kind of negative, to be honest. So ideally, you come in and you really normalize this discussion because this is an incredible transition and it can be very, very stressful, right, for anybody. So I'm not even talking depression, anxiety, any of these conditions. I'm saying just transition to parenthood is stressful and can be overwhelming. So let's just talk about it, right? And I say the earlier the better. Start the screening process 3 times, once each trimester in the pregnancy, at least once postpartum. But ideally, this is done. So what we do at Cedars is we screen right after delivery, which we realize is less than ideal because you could be picking up prenatal symptoms or baby blues, right? But we have patients coming from 5 different counties to deliver at our hospital. We deliver 6,500 babies per year. So we don't know what's going to happen once they leave. We just can't trust that they're going to get screened ever again. So we do it, and anybody who screens above a certain cutoff, our outpatient social work team waits about 6 to 8 weeks and then contacts them, rescreens, checks in, how are you doing, follows up. In the best outpatient clinics, that screening's happening already in the 6-week postpartum visit. And in an ideal world, you're being screened again at additional postpartum visits. And I'll say primarily because there are other times in your postpartum journey where you could be at high risk. So a later high risk time to develop a PMAD is, for example, when you stop lactating. So if you are breastfeeding, if you are lactating, your hormones are in flux, and when you start and then when you stop. And so you could then be at 7 months, 8 months, 12 months postpartum now at risk again. So that's why I always encourage all my OB-GYN colleagues to repeatedly screen with reliable and validated screening tools, educating and referring multiple times.
Thank you, Dr. Accortt. That's so valuable, because I know that in my experience just a few years ago, I didn't have that. And just hearing you go through all of that pre-screening, if I had that, I think, especially with a pre-existing mental condition, anxiety, which I'd had since I was 18, I think that I might have been better prepared for what I ended up experiencing postpartum. So I definitely think that pre-screening is so vital. So thank you. Okay, my next question, there's a few questions actually. I'll try to group them together as best I can. For Dr. Bamgbose, what does medical treatment look like for perinatal mood and anxiety disorders? Can depression and anxiety during pregnancy or after birth affect my baby? Is mental health medication safe during pregnancy? I'll stop right there for now.
It's a good bundle of questions because they all kind of connect with each other. So I think the general idea in terms of when me as a psychiatrist and OBGYNs and any person who's providing medication, we talk about, okay, therapy hasn't been working, support groups haven't been working, exercise, all the other things that you're implementing are not working, then we think about it might be time to use medication to augment treatment. The typical treatment that we use for postpartum, for perinatal mood and anxiety disorders are typically going to be your antidepressants. We think of things like Zoloft as the brand name, or Prozac or Lexapro. Those are the ones people are most familiar with. Other antidepressants such as Wellbutrin. Other class of medications for some people, if they're not responding to these medications, we might consider mood stabilizers, which include antipsychotic medications and the mood stabilizers. Now, everybody doesn't need all those medications. Everybody doesn't need high doses of all these medications. I've had a lot of people who responded really well to low doses of, for example, Zoloft for a time-limited period of time. And so it really is a nuanced discussion with you and your psychiatrist or whoever you're talking with who's providing your medication about what medication can be helpful. So that's one aspect. There are, if these medications are not really working and so people are still having symptoms despite being on medication, there are other things to consider. There's been a lot of news recently about a couple of new FDA-approved treatments. The first FDA-approved treatments for postpartum depression, the first one was called brexanolone Zulresso, which came out several years ago, which was a 60-hour IV infusion, which was not well prescribed because nobody could get it, and 60 hours is a really long time. So that really hasn't been used very much. And then the one that was most recently approved last year is called zuranolone, and I think it's called Zurzuvae or something, the brand name. It's like some exciting Z name. And so those are really promising treatments for people, or especially the most recent one, the pill, because it's a 14-day time-limited course that people seem to notice improvement in symptoms. Of course, unfortunately, the way that insurance companies go this year, often it's very hard to get these new medications without having failed other things. So that's something that is probably not going to be widely available to people at this time. But there are also things that you'd want to think about. You don't always have to do a pharmaceutical, such as an antidepressant. There are treatments like transcranial magnetic therapy, which is it's actually a magnetic impulse that's delivered to the brain. You're awake, you're reading, you're watching TV or something, and it helps rewire the neural networks in the brain that are causing depression and anxiety. So that can be an effective treatment as well for depression in the perinatal period, and is safe for people who are pregnant or nursing. And then thinking about the reason why we talk about, okay, the symptoms aren't getting better, so we need to treat them. Why is that such a big deal? Because there actually is evidence that a person who had an untreated depression or anxiety during pregnancy, this does have an impact on their unborn child. The unborn child has increased risks of depression and anxiety. There are increased risks of birth complications, such as preterm delivery and low birth weight children. And so those are pretty serious things that we'd like to avoid if possible, of course. there also isn't any clear evidence that taking these medications increases negative birth outcomes. So we see, of course, the studies when they come out and they'll say, oh, this antidepressant causes heart defects or this one causes autism. So they come out, but they're based on small numbers. They haven't really been able to account for what's actually happening in the population that they're studying. And then later, but they don't get as much press, the studies come out that actually, for the most part, any medication a doctor's going to prescribe you when you're pregnant or postpartum has been shown to be relatively safe for a child. And when we weigh that against the risk of being very depressed in the postpartum period, for example, where I mentioned before, if you're not getting out of bed, you're not feeding your baby, you're not bathing, you're not doing anything, that's very risky for the child and for you. So we really want to look at those alternatives. We call it a risk-benefit alternative analysis. What are the risks to treatment? What are the risks to not treatment? And what are the alternatives if we go either way? So I think I answered all three parts of your question.
I think you did. And you lightly touched on this next question, and I love this question because it's about access to care. What are your thoughts on access to care? Both new moms with and without insurance have problems accessing the right care.
Mm-hmm. Oh, it's such a great question. And we know in general, if anyone who's not even a new mom and they're like, I need to see a psychiatrist, I need to see a therapist, it feels impossible to find somebody who's in network, or who, if they are in network, if they're taking new clients, then if they are taking new clients, do they fit your schedule? So it's really hard in general. And then for this particular specialty of people who are comfortable treating people when they are wanting to get pregnant, when they are pregnant in the postpartum period, that drops the number of people even further down. So people, because understandably there aren't any, they worry, of course, about the potential outcomes for the baby if they're treating a pregnant person. So I think access to care right now is not where we need it to be, of course, but there's a lot of different ways that people are working on changing that. So I think especially with organizations that we work at, with Cedars-Sinai and with Watts Healthcare and Maternal Mental Health Now and NAMI and Postpartum Support International, there's all these really great organizations that work on improving education for providers. They have support lines so that if your doctor doesn't actually know how to treat this, but there isn't a reproductive psychiatrist around, they can call and get guidance on this. So there are some options. And I'm hoping that eventually more psychiatrists will start taking insurance and being in networks so that people can use their benefits, because, I think we talked earlier about this. So many psychiatrists in the cash pay world are hundreds of dollars for a 25-minute session, and 99% of people can't afford that. So it's definitely something that I want to make sure that people have access to, and I'm definitely advocating for that.
I love that. I know when I was looking for a psychiatrist and a therapist during the pandemic, during my experience, it was really, really difficult. Everybody had like 6-month wait times, and some people weren't answering their phone. And no, I could not afford $500 an hour. So, access to care is something that I think is getting a lot better, but isn't where it needs to be yet. Mm-hmm. So thank you. One more question for you at this moment. There are statistics that show that there is a higher prevalence of perinatal illness in the Black community. Can you talk a little bit about this?
Of course. It's an unfortunate reality. Dr. Accortt mentioned it a little bit when she talked about how racism is a risk factor for perinatal mood and anxiety disorders. And we see it when we're talking to women and they're being discriminated against at the doctor, and their symptoms aren't being taken seriously. They're being told it's all in their head or to just forget about it. So there's that. They're being dismissed by the medical profession. Maybe their families are not really that supportive of mental health challenges, and so they feel like they can't go to their families for support. And then one thing I think that Dr. Eynav Accortt had mentioned earlier was that birth trauma or NICU experiences also that's so stressful, and that can have a high impact. Well, unfortunately, Black women are at much higher risk of birth trauma, and in terms of prenatal neonatal complications and maternal morbidity, which means anything in terms of from diabetes or hypertension to preeclampsia, emergency C-sections, any complication that can happen. So these women are having higher rates of complications. It stands to reason that they're at risk for being, they're higher risk for experiencing a perinatal mood and anxiety disorder. So I think that's something that we all in our work, we think about, we recognize, we think about the ways, how can we be really supportive to those more vulnerable members of the community who are more susceptible to these disorders.
Thank you. Okay, our next few questions are for Anita. So when it comes to underserved communities, such as the Black and Latinx communities that you primarily serve through WATS, what are the biggest issues when it comes to access to care?
Okay, so to start off, I'm going to piggyback what you guys said pertaining to, yes, the history and the current discrimination and feeling like their voice is being heard. So that is definitely a barrier of actually making it to the doctor's appointment, actually coming in and connecting to the services. Another thing we have noticed here at Watts is a location, so transportation. Just because you're seen here at Watts doesn't mean that you live close by Watts. So, catching the bus, the train, the car is definitely a barrier for getting access to care and making your appointments and getting your needs met. Also, in language barriers. And being able to communicate. We have patients who speak Spanish and other languages also. So we have to make sure that there's interpreters, that we are able to have the professionals to be able to provide that and access to that to make sure that everyone is being able to communicate what their need is medically and when it pertains to mental health. So that's another one. And another one is just the literacy when it pertains to health information, how the information is given to the patients, that they're understanding their diagnosis, they're understanding what triggers mean, they're understanding what coping skills. So the education behind the diagnosis, what this assessment means, the process of the assessment. So that's the whole literacy of the healthcare system is another barrier. And also socioeconomical stressors, the everyday stressors, housing, food. So a lot of our patients, if their needs aren't being met here, it's hard for them to be concerned with what's going on when it pertains to postpartum perinatal care. They're more looking at, am I going to be able to eat? Am I going to be able to feed my family? So I think those are things that are barriers for, being connected and maintaining and keeping the follow-up of the care pertaining to mental health for our patients. What I've noticed here.
Thank you. What about substance abuse? Does that play a role in the prevalence of perinatal illness in these communities? What do you think of resources like Warm Lines and 988 for crisis situations? Are they enough? Are they effective, etc.?
Pertaining to substance abuse, I have definitely seen a rise with marijuana. Marijuana is a lot of our moms have to come in for trimester assessments. They come in, there's screening, of course there's blood tests, there's urinalysis, and usually if there's something is identified, there's a process, there's education that's provided. And we let them know that, this can affect you mentally, medically, during the pregnancy and postpartum. It can worsen if you have symptoms or a diagnosis, and it will affect the fetal process development. Low birth weight, it could be cognitive issues. There could be a lot of concerns based upon, consuming substance during the pregnancy and after the pregnancy. And then we also have to take into account if there are psychosocial stressors. So if someone is dealing with domestic violence, partner abuse, if they're dealing with other crises with work, and sometimes those things can go hand in hand with substance abuse, and you're dealing with other substances, so it can make the situation more, elevated. So a lot of it is just the education about that, about the effects on the mom, the baby, how it can affect before, postpartum, and the resources. So that's how I can tie in with 988 and the warm line, because those two services are firsthand resources. You know, they're 24/7, at least for the 988, and the hours for the warm line throughout the day. So those are two good ways to be connected to services if you're not able to work off of, like we were talking about, the safety plan. You know, if you can't get the friends or the family that are on the safety plan, you know that you have the crisis 98 number 24/7. So the good things about that, like with the warm line, there's peer support, you know, someone who can build rapport with you, someone who can, you know, help you stabilize your mood and be of support in that moment. Also with the 988, referrals are provided. So that's also a good thing. The referrals are provided, there can be follow-up, and also there's a state of having someone addressing those immediate needs and getting you connected, and also being able to de-escalate the emotions and the moods that you're feeling in that moment. So I think that's how, you know, it benefits. And of course, everything has its pros and cons. So when I look at the cons, it's more of, you know, just access, you know, people having the awareness of the programs, and also providers, people who are able to do the work. You know, is there enough people to be the fluctuation of people who are going through mental health crises? You know, is there someone to pick up? You know, how immediate are their needs being addressed? And are they able to seek it in a timely manner based upon who's available at the time?
You know that we at CalHOPE, we have our warm line that's available 7 days a week. We have quite a few moms that are peer support specialists, and we can definitely help to de-escalate a situation and emotions and connect them to 988 if needed. So just putting that out there. Thank you. Our next question is for Dr. Bamgbose. What do you make of the increased coverage of late on postpartum psychosis? Is there more occurrence or just increased attention on it? Can you tell us the difference between intrusive thoughts from OCD, which is not an emergency, and postpartum psychosis, which is an emergency?
Yeah. I think I'll start first by talking about the difference between the two. So intrusive thoughts that are involved in obsessive compulsive disorder, I always think of them, it's like they're these sticky thoughts that come in your head, and no matter what you can do, you don't want it there, but it came and you can't get it out. So what does that look like for people? A lot of people tell me that they're really weird stuff that freaks them out. Like they'll say, oh, I'm changing the baby, and I just thought, what if I just threw the baby on the ground? Like, no, you're not going to do that. You don't want to do that. There's no risk of you doing that, but that thought gets in there, and it can become really disturbing for people, and they start to wonder, is this what's happening? Am I a bad parent? I think up to 70% of new moms experience this, and also a significant percent of the non-birthing parent also experiences these types of thoughts. So knowing that they happen, it's okay. Then you can say, I'm having this thought. This is a weird thought. I'm going to let this thought go away. I'm not going to act on this thought. And so being able to talk about it, for example, in a support group, or being able to share with your doctor needs to know what an intrusive thought is. So they're not like, you want to throw your baby on the floor? No, I don't want to throw my baby on the floor, but I'm afraid I'm going to. There's a difference. And then, so that's an intrusive thought, which can really respond well to certain types of therapy or medication, antidepressants and anti-anxiety medication. But then on the flip side, there's postpartum psychosis, which people who have a history of psychosis or a history of bipolar disorder are more likely to experience postpartum psychosis. Unfortunately, it occurs in about 1% of births. So postpartum psychosis, somebody starts to have delusional thoughts or paranoid thoughts. So they're not thinking, oh, what if I threw my baby on the ground? I don't want to do that. It might get to the point where they're thinking, oh, my child is inhabited by Satan, and the only way to save it is if I throw it out the window. And that's a really scary situation. That's definitely an emergency, because then they're not thinking straight, they're not living in reality. And so the chances of acting on that thought are very high. And I think that leads us to the coverage of it, because we've heard of unfortunately in LA County, so many, and then on national news. I don't know that it's any more common than it has been before, but I think with social media and the way that the media is, we just are hearing about it more. And it's so sad because when you read these stories, you hear about how they went to the doctor, they were getting treatment, and it still wasn't really enough for them because they weren't getting the right type of treatment. I think one of the things to really know about postpartum psychosis, it's so rare. We obviously hope none of us here, nobody watching will ever see anybody with it or experience it. But in the event that you do, it's important to note that people can seem fine 1 second and not fine the next second. So if you're noticing that there's something weird happening, that's definitely an emergency, and we can't assume they're fine the next day. So I think those are the main things when somebody's just acting much different than they were before, weird religious beliefs or weird thoughts that they would never have said before. They worry that people are after them. They're hearing helicopters. They're not sleeping. These are all signs that it's an emergency. We need to take that person to get treated.
I know when I suffered from postpartum OCD, I had really bad intrusive thoughts, and nobody to tell me that that's what was going on. I just was having these thoughts that made me afraid to bathe my baby, made me afraid to put the baby to bed. I was afraid I would do something to myself even because I knew I was the mother and I had so much responsibility, and I was worried something was going to happen to me. And it was all irrational and not part of my character at all. And I think it was Dr. Accortt who said there's 70% of parents, if that's correct, that's the correct statistic, have these thoughts. So it's really not as uncommon as some might think. So yeah, I wish I had somebody, a medical professional, to tell me what was going on with me sooner back when I was going through it. It was horrible.
Yeah.
But luckily not psychosis, right? So yeah, and it was still horrible.
Traumatic.
Totally experience. Yeah. Okay. Our next question is for you, Dr. Accortt. It's a group of questions, so let me try to group them together as best I can. What are your thoughts on managing the stress of sleep deprivation and breastfeeding/lactation for new families, specifically the focus on breastfeeding in hospitals right after birth? Many moms become stressed about breastfeeding, and this must contribute to their overall mental health. I definitely was stressed out by it, by the way. So, yeah. Okay, well, what do you think?
Absolutely. Okay, so let me start with the sleep deprivation, just sort of piggybacking off of Dr. Bambose's excellent description about postpartum psychosis. And I think it's important to be aware that if you are very sleep deprived for many days in a row, you might hallucinate as a sort of symptom or side effect of that. You might hear things that other people aren't hearing, but a good night's sleep will make that all go away, right? So unlike someone with postpartum psychosis, even if given the opportunity to sleep, I always think about this hypothetical situation, right? Where, again, very hypothetical, the cleaning crews come through, your mother-in-law's come, the to-do list is done, you have a dark, quiet, clean room, and you can just get into bed and sleep as long as you possibly want, right? Someone with postpartum psychosis won't be able to do that. And someone with really severe postpartum anxiety may also struggle with that, tossing, turning, worrying. So I do want to kind of be clear that no matter what, for all new parents, sleep is an issue. It is a struggle. The struggle is real. And all of us are going to go through it. And so what I will recommend to all of our patients, and in fact, we have a Preparing for Postpartum Wellness class that's open to anybody who delivers at Cedars, and it is to educate around this issue of sleep deprivation. We do talk about lactation and other things. And the point that I make is that sleep in the postpartum period is not a luxury, it's a necessity. You must get not all one long block, but blocks of 2 to 3 hours that add up to a reasonable amount of sleep. And that must happen. It must be provided, protected somehow, whether it's your spouse, your mother, your mother-in-law, someone you pay if you can afford it. There's got to be some way to get this online so that we aren't overly sleep deprived, because one of the other risk factors for postpartum depression, postpartum anxiety, as I said, not psychosis, but hallucinations and other symptoms, is the sleep deprivation. We also know that sleep is the time where our immune system is working its hardest and where we're able to repair, right, physically. So our body, whether you have a vaginal delivery and you've got a plate-sized hole where your placenta came out and you need to repair, or whether you've had a C-section, you had full-blown surgery, you need to repair, this happens during sleep. So you're not going to be able to recover physiologically, physically, or mentally and emotionally from your delivery experience if you're not protecting your sleep. So I will always recommend that this conversation around protecting one's sleep is had during the pregnancy. Get the partners in the room, get them talking about it, get them thinking about either creative ways, whether it's napping, whether it's someone showing up, mother-in-law shows up at 6 a.m. So after that first feeding, she takes the baby and you go to bed. We think about that in sort of combination with breastfeeding and lactating, right? So that kind of leads me into my answer about that. A lot of stress and pressure around breastfeeding. And you will hear people say that breast is best, breast is best. Okay, well, a healthy baby and a healthy mom is best, in my opinion. However way this baby can be fed so that it's healthy and mom can remain sane is best. Now, there is good data, epidemiological data, that shows that 6 months of breastfeeding, even if it's not what we call exclusive, so even if you're breastfeeding 2 out of 6 feedings, that protects mom against breast cancer. That improves baby's immune function. So I'm not saying breastfeeding isn't great and lactating isn't great. It is great, and we want to encourage it without pressuring, pushing, and making new mothers feel like that's their only option, and or that it is an all or nothing situation. This doesn't need to be all or nothing. One can, as I said, breastfeed, put the baby to breast half of those sessions, and the other half of the time there's pumping and bottle feeding. I think in an ideal world, there would be a lot more support around breastfeeding and lactation, and around also bottle feeding and alternate feeding experiences. And what I think is important is to realize that no matter how you're feeding your baby, it can be stressful because the baby could be tongue-tied, there could be reflux, there could be so many things that get in the way of baby eating, feeding effectively, whether that's breast or bottle. So going into this, giving yourself grace, realizing this isn't something that's intuitive and natural and all the stuff that the media, I think movies and all that. No, this is a skill and we learn it. We do not know what the heck we're doing just because we have breasts. So it's a learning process. So giving yourself grace to understand, we don't know how to breastfeed. We don't even know how to pump. We don't know what we're doing. We need to learn. We want to learn. And we want to include the non-breast having, let's say perhaps, or even if they have breasts, but they're not lactating. We want to include the partners. So when I think about this combination of the stress of breastfeeding and sleep deprivation, because they go hand in hand, you're waking up every 2 hours because your baby's screaming and crying, okay? You could put baby to breast, you could feed this baby, and then that could be 30 minutes. Okay, that's going to disrupt your sleep, for sure. The question is, can you then hand baby off to partner, friend, best friend, sister, brother, mother-in-law, and that person then goes and burps and changes the diaper and rocks baby back to sleep? That's another 30, 40 minutes. When mom or the breastfeeding person could be back to bed, take the baby to another room and do all of that. Be an equal partner. But these things have to be discussed in advance. There can't be assumptions. I'm afraid that The assumptions are that fortunately, mom does everything. And I don't think that's a very healthy way of going into this, because then there will be a really severe stress because no one person can do it all. We can't do all the things and be healthy and well, right? So that's what I have to say about managing sleep deprivation and lactation-related stress.
I really wish someone had told me about all of that before I had my baby. I had my baby during the epidemic, so my mom and dad couldn't come stay with me. I thought it was just me. It was all on me. And she had lost weight in the hospital, so they did want us to wake her up and feed her every 2 hours. So luckily, my husband was a saint, but eventually my mother-in-law did have to come in and save the day, because you do need that extra help. And I don't think a lot of moms realize that, or are told that, or plan for that during their first pregnancy. They learn that as they go, So yeah, I definitely think it's important to let moms and dads know that, to plan for that ahead of time. It's a lifesaver. Okay. It is already almost 7, or it is 7 on the dot. I have a question for I know time just flies. I have a question for all three of you. What can we be hopeful about in the future, and how have our awareness and treatment options grown for perinatal mood and anxiety disorders of late? I don't know who wants to go first.
I'll start.
Okay, great.
I think in terms of what we can be hopeful about, I think things like this, where because of social media, because of that, we can share these experiences and have more people having access to these conversations, because of more people who know what to look for, what to think about. I think it's going to be so helpful. And also, I think the more within this space, I feel like people are realizing that it's not just the OB, which OBs are great, of course, but it's not just the medical community. It can be, their social workers, their support groups, their community members. Because as I always tell my patients, I'm like, humans were not made to just raise a child, 2 parents and 1 child. That's not normal. It doesn't, we're meant to have a village and have those people around. So being able to create your chosen village. So I'm really hopeful that people are getting back into that mindset, and I'm excited about that, and excited that there's more interest and awareness on the medical side and the pharmaceutical side of how to safely research what's safe for our mothers and for pregnant people, and how we can treat them and their families.
And I'll piggyback that. I agree. It takes a village. It definitely takes a village. And just like you said, panels like this, getting together, the discussion, even if it's not in person, webinar and social media has that going for itself, that we can have dialogues, we can post awareness, we can educate, we can educate our communities, the nation and the world, by our stories, by our own experiences, and by just educating professionals, and also the moms to be, and the moms who are dealing with the current stressors, and just being creative as a clinician, and just being a therapist, just being creative on how to connect our patients and keep them connected, keep them invested in the care of their family, their well-being, because it's foundational. If we lay a solid foundation with the mother and the child, their outcomes are better mentally and physically. So that's where you have to come from, building rapport and being creative in that rapport with our patients.
I love that, Anita. I completely and wholeheartedly agree. And one thing that I'm hopeful about, and just how much I've seen change over the past 15 years that I've been working in this field, specifically in perinatal mental health, is that, 15 years ago, you were really on your own. You were lucky if you had an OB-GYN who would even ask you about how you were feeling emotionally at all. And if you did answer, I'm struggling, they would have a piece of paper with a list of some people on there. And that hadn't changed in probably 10, 15, 20 years. And we hear about that. I hear from my patients, oh yeah, when I had my kid 10 years ago, 15 years ago, I got this piece of paper. I was so overwhelmed and anxious and exhausted and depressed. I didn't have the energy to call these people. When I finally did make a couple phone calls, one of them never answered. One of them was just a disconnected line. One of them, somebody answered and said, oh, that person has died. I mean, it was just like, these are not these static lists. They don't work. That's not how we can provide that foundation and that support in a creative way, right, Anita? Like, we can't do that. And so what I'm really hopeful about is, for example, what we're doing at Cedars with patient navigation. So even though we aren't a huge team of mental health providers, we do have our excellent patient navigators who are licensed clinical social workers who will do a thorough assessment on the phone or virtually like this, gather information about what kind of insurance company, or whatever your network, and already have an awareness of what's in the community, what's available, what's low cost or low fee, what's Watts doing, what's NAMI got, what's PSI got. Oh, you had a perinatal loss. Well, we've got a support group for that, or they have a support group. So being connected and in an ongoing basis, refreshing those connections, renewing those connections, learning about, support in the community and providing those links is critical for this time of life because, well, it's always critical when someone is struggling with mental illness, right? But the difference between this, perinatal mood and anxiety disorders, is you're not pregnant forever, right? So if you're really struggling, you need help, you need it now. You're not lactating or postpartum forever. You need the help now. So we need somebody who is knowledgeable in these conditions to screen and educate and refer, ideally to someone in network. And I'm just seeing so much growth in the perinatal mental health certification and all these offerings. I'm very hopeful.
Great. Thank you, all three of you. So we are going to have time for Q&A as we're nearing the end of our time together. But before we do that, and just a reminder, if you have a question, please drop it into the chat and we'll get to that next. But I want to first give each of you some time to talk about the projects you're currently working on with regard to maternal mental health and PMAN. So who would like to go, or would you like me to? Dr. Accortt, why don't you go first?
Yeah, I'm happy to, and I so appreciate the opportunity because we're very excited about our new NIH-funded RISE study, and that's an acronym. The RISE study stands for Resources, Inspiration, Support, and Empowerment. This is RISE for Black Maternal Mental Health. This is a randomized controlled trial. Dr. Bamgbose is the reproductive psychiatrist investigator on the team. Dr. Kimberly Gregory is our maternal fetal medicine or OB-GYN physician on the team. And then our community partners are Maternal Mental Health Now, that I know Anita is very involved in, and Candlelit Care, which is an amazing organization out of North Carolina. The purpose, and I'll be brief because I could talk about this all night. I'm really excited about it. But the purpose is to really address one of the issues anyway that we discussed tonight, which is that Black women are twice as likely as white women to develop PNATs, or perinatal mood and anxiety disorder. In addition, they're less likely to seek mental health treatment, as Dr. Bamgbose spoke about. So we know that Black patients report racial discrimination in medical settings, worse communication with their white physicians, and that may be why they're likely to decline therapy or medication. So the idea with this trial is we are looking to see whether a new mental health and maternal mental health specific mobile health and wellness app is effective in reducing stress and potentially improving outcomes. So that's not just PMEDs, but also physical symptoms, specifically in Black pregnant individuals. So we're recruiting a total of 150 pregnant Black women anywhere in the United States. So most of everything we do is virtual. And so we are looking for anyone who identifies as Black, is at least 18 years of age, is around 12 to 32 weeks pregnant. And we would just have you answer some questions and surveys and then engage with a mobile web application during your pregnancy. And then we follow you through your delivery of postpartum and have you fill out some surveys afterwards. Compensation is provided, so we hope that individuals would be interested. And if it's okay with you, Lagaya, while Sinmi and Anita speak, I can put the link in our chat. So if you have any interest, or you have a patient, or you have a friend who might be interested, then you can share that. And that's a direct link to our RISE study interest form.
Sure. Yes. Please put it in the chat. We'll share it after the webinar.
Thank you so much.
Yes. Thank you. Anita, do you want to go next?
Yes. I could talk a little bit about the Maternal Mental Health now. We actually have a Black Birth Workers Council that I'm a part of. And also, Sinmi, she's also a part of it. And our council, pretty much, we get together with other professionals and we talk and deal with different topics. We have different trainings. We have networking socials. We have wellness programs, conferences to be support for other providers, such as, we have we have doulas, we have doctors, we have therapists, and all of these are Black workers in the field of maternal care. And what we do is we support other providers by educating them, putting the word out on what we promote, and also about the resources. And one of the resources that's available to the community is the HealthWise resource. This resource is pretty much, it looks like a map system, but pretty much the system is made for people to get on from the community and talk about their experience of what's in their community. If it's pertaining to diapers, food, daycares, so they can review it, they can pinpoint it on the map, and other people can go in and add the resources and give their reviews, how they felt about it, what they can get from it. So it's like a big grid of all the community, all the different resources and services in the LA community. It's called HealthWise. And I guess we could add that information or we can follow up on that. So that's a great resource just overall for the communities, along with us working with Black birth workers. Like I said, providing the education, bringing it back to our facilities, and advocating for the staff to bring awareness to the concerns, the challenges for Black women, Black birthing women, and also postpartum times, what the needs are, what's being said, and what the outcomes could be if everything was being brought to light and educated on, and also just advocating for the cause. Mm-hmm.
Yeah, if there's any links that you want to share, just go ahead and you can also email them to me and make sure that we share afterwards. So, okay, last but not least, Dr. Bamgbose.
Well, I think it's so wonderful for me that I get to share both of the items that were talked about. I get to work with these lovely ladies on these projects. So that's a wonderful part of my life. And when I'm not working with maternal mental health now or Cedars-Sinai, I have a private practice focused on women's mental health and a lot of these maternal mental health issues. And in the working with insurance companies, even though they're really stressful to work with, but I feel like it's so important to have that. And so what I'm really excited about is being able to increase the pool of providers who are in network with people's insurance. So that's what I've been working on recently. And also we'll put that information in the chat or in the wrap up later.
Great. I definitely think in-network providers would be more in-network providers would be wonderful. I know from like my friends and moms that are recent moms that, that would just be something that would be if it was more accessible, that would be great for new moms. So thank you for sharing your projects. Donnell says we have 4 or 5 questions in the chat, and I'm not seeing them, Donnell. So do you want to maybe ask them? And since I can't see them for some reason.
Yeah, they came direct to me, which is okay.
Oh,
yes. So the first question is, if a pregnant woman goes to a physician, psychiatrist, MSW, who is of their same race and ethnicity, are they more likely to listen, feel comfortable in discussing their mental health issues, And do they have better outcomes as a result?
I can start addressing that. I think the short answer is probably and yes. That then when there have been studies that when people are treated by like Black infants or Black women are treated by a Black provider, that the outcomes are better. And so I think that's wonderful to know from a data perspective, but also just anecdotally, I know that in my experience when I've had patients who come to my office and they said, I've been just waiting to see you for so long. I've been looking for a Black psychiatrist because we are few and far between. And clinically, I hope their outcomes are better. I don't know, but in the experience, but it does seem to be for a lot of people a better experience, which is wonderful to see.
Yeah, I've read that research too. Sinmi, I agree. I think that it looks very, very likely that if you are seeing a provider who looks like you or from your background, cultural background, the outcomes are better, not just self-report, oh, I like that experience better. But I think that isn't to say that we can't all grow our cultural competence. So I think it's important to realize that, there are so few reproductive psychiatrists, right? And then even fewer Black reproductive psychiatrists. So I would hope that your white or Asian or whatever colleagues, Dr. B, are gaining in cultural competence so that they can work with individuals who don't look like them, because you guys are so rare and so amazing. You're like unicorns. And so I too will seek out opportunities to really improve and gain more cultural humility and really strive to be able to work with individuals who are not my race or my culture.
I agree. We have a lot of trainings in our profession on cultural competency. And it is true, usually, especially with the mistrust of different providers, sometimes when you do see someone who you feel you can connect with, based upon it could be culture, it could be skin color, all of the above, sometimes it's easier to break down that wall before it's even put up. It's easier to build rapport. But like you said, Ms. Accortt, Dr. Accortt, that's not even the case when you're able to just be there in the moment and have a soundboard of, I'm meeting you where you're at and I'm recognizing for who you are in your flight. So I think a lot of it has to do with training, education, and just being very open-minded, that everybody comes with their own story. Because I have different clinicians here, and some of them did have a issue with connecting with clinicians from different backgrounds. And through that, we talked about that. Like, okay, well, we all have to, where do I buy in on that? And what is it for the patient? We got to look at both point of views where we can come together and find common ground. Everybody has something that they can find common ground on, regardless of their race.
Awesome. Thank you. The next one is what's needed in terms of policy solutions for better screenings and prevention of PMADs? For example, not just screenings on symptoms, but risk factors, like if someone has a family history of anxiety, depression, mood disorders, bipolar, etc.
So I can just speak a little bit to that. I don't do as much advocacy work as I think I would like. But there's a lot that one can get involved in. And I think it's important if you're interested in this. Of course, I remember them by their original name of 2020 Mom, but the Policy Center for Maternal Mental Health is what I would encourage that person asking the question and others to reach out. And you're going to be able, and I put that in the chat for Donnell to share, that if you're really interested in what's going on with policy and new bills and things that we, meaning the field, are working on, that would be the place to get the most up to date. Thank you, Donnell. But I know from my perspective, I was really honored to be invited with Maternal Mental Health Now and 2020 Mom to go up to Sacramento back in 2017 or it was 2018, right? Because we had already started our postpartum depression screening education and referral program at Cedars. And I went to speak to testify up in Sacramento to say, this is what we are doing, and this is what hospitals need to do. And yes, this bill is really important. And that bill then became law the following year. There was a bundle of bills, I would say, that all went into effect. So it's exciting to see that even just in the past handful of years, there's been action, there's been change. And so I think, if you'd like to educate yourself more around that, I do encourage you to get involved, because we need you.
That's awesome. And yes, I was actually sharing with Ligaya just before we started. 2020 Mom was founded by a mom that lives out by me. It's an organization I've been involved in. They do amazing.
That's really great.
They do amazing policy work. And I agree. It's really about just getting involved and, being a part of making the voices heard, for sure. So thank you. That's awesome. The next question actually comes from somebody who I think sounds like from a child of somebody who maybe had struggled. The question is, I battle with PTSD, post-traumatic stress disorder, due to my biological mother doing something she wasn't supposed to expose me to. How can I deal with this when someone in my life keeps bringing up, for example, gift cards that my biological parents used to distract me with? So it sounds perhaps, a child of somebody who had a mom who maybe struggled in some capacity with postpartum or perinatal.
I think that's such a terrible situation. It sounds like that happened when you were growing up, and that still affects this person today. So I'm sorry to hear about that. I think with this type of thing, it's such a complex thing, because there's people around you who are making assumptions about what your relationship might be like with that person, and or you might not know about your own PTSD symptoms. And so I think in this situation, being able to hopefully get in touch with a good therapist, either with one of the resources that we shared today, or be getting connected there, so that you can start that healing journey to manage the things that are triggering you, and also be able to learn how to express that to other people, so that you can maintain your own boundaries and try to protect yourself from people, whether they're acting with malintent or not.
That's awesome. Thank you. We have two more. This person says, I had severe postpartum psychosis at the 8-week after birth period and needed hospitalization. I was in another world, totally alienated from reality. It was my third child. I had had severe symptoms after the first birth, but with an analyst, they healed on their own. After our second child, there were mild symptoms of the level you are all talking about, like depression. So it seems symptoms were growing more manageable, but it's not so. After the third birth, I was in a hospital 5 months. Hospitals were of huge importance in 1960, and before drugs were perfected and before substance abuse was common, there were a group of us in that hospital with postpartum psychosis, so it is not so rare. What do you do with those mothers?
I think that question is, and I agree, there's a couple things that come up, I think, in that question. One is that, unfortunately, when you have that experience of severe depression or postpartum psychosis, which, again, and I'm so sorry you went through that, it does make you, as you experience, more likely to have another episode. So that's something that we see. And I'm not sure what exactly the hospital situation was like for you in the 1960s, but I think the idea that you were able to be with other moms is unfortunately something that pretty much doesn't exist in this country in that capacity. There's, I think, 3 places, one in the Bay Area, one in North Carolina, and maybe one other place where people with postpartum women can be specifically treated for their depression, suicidal ideation, psychosis, and have their babies with them, or have other moms around them who are going through a similar thing. So your question of what we do with those women and with those mothers is not enough. We're not doing enough. We don't have a good system for them, because when somebody is hospitalized, the way it is now, they have to be separated from their family. Oftentimes, if they're trying to pump, they're not allowed to have a place to pump, or they're not allowed to have a place to store their milk that's pumped. And so it's just a really traumatic experience for the whole family. And so that's something that I know some organizations are trying to fill that gap in terms of intensive outpatient programs, which is more of an intense day program. But I'm hopeful that eventually we'll have more mother-baby units because they have them in Europe, but they have them in other countries. So that experience, we're not leaving those mothers behind.
Yeah, I might just think, thanks, Sinmi. I agree. We need more. We need more of all of the things. But there are, I should say, a few options, even locally. So like partial hospitalization programs where you go for the day, let's say, and you get specific maternal mental health intervention, and you can bring your baby and then you go home to sleep. So there's makeshift. Again, I agree with Sinmi. Like if we could have what North Carolina has set up at UNC Chapel Hill, which is the mother baby unit, and a couple others in this country, if we could have that at every major birthing hospital, that's what I want to see. When we say we're hopeful about the future, I think we will. I think by the time, Sinmi and Anita and Lagai and I are retiring, we're going to be like, look at how far we've come, because every major city in this country has an excellent mother baby unit. But we are moving forward. There are, since the 60s, there are hospitalization programs that they're not mother baby, but they're really good in bringing in reproductive psychiatrists or having specific specialized care for mothers. And even if you don't, I've had patients who were hospitalized in a more general kind of psychiatric ward and had really good experiences. I would never say to be scared of that kind of environment, because it's an opportunity. Obviously, we could do better. But even as it stands right now, if you're not able to function, you can't take care of your baby, you're not able to take care of yourself, this is where you need to be so that you can heal. And these are caring, compassionate caregivers who are at these hospitals right now, today, even if it's not specific to maternal mental health. So I encourage you to seek out that kind of care.
That's awesome. Thank you. Last one that I have is my maternity leave ends mid-June. I have been waiting for a psychiatrist appointment for a few weeks and finally have one June 5th. I know I'm not ready to go back to work due to severe anxiety and birth trauma from almost losing my life. I'm stressing that they won't think I need more time off. Is it okay to straight up ask for more time, or does that come across as if I'm just lazy and looking for an excuse not to go back?
I'll take this one too. I think no, I don't think it comes across as lazy. And I think if the person that is seeing you thinks that, then that's not going to be a great match, right? It's not. But I think people need time to heal after birth trauma and PTSD, and so it's a very reasonable request to extend that disability period, because going back too early can really make the symptoms much worse. So I'm hopeful that the person that you're going to get to talk to is going to be understanding and be able to help you with that.
Awesome. Thank you. Thank you, ladies. Those are the questions I have. I think Lagaya has a few as well.
Yes, I have one. What advice can we give for women in leadership roles that are dealing with these symptoms and their families? I think that's a great question. So women in leadership roles.
Yeah.
Wants to take that one.
I mean, I haven't really given that a lot of thought. Anita, I see you come off mute, so I'd rather you take it. I would just say that I would hope that everyone feels comfortable talking about their experience. And something you had said before, Anita, that really struck me was about telling your story, speaking out, speaking up when you're down, as we like to say. And someone who's in a leadership role, wow, the power, right?
Right.
I'll let you speak on that.
You're absolutely right. I think a lot of it comes back to we're all human. We're all living a human experience. So regardless of our role, even if it's in leadership, if we're above, below, we're still experiencing parts throughout our life cycle. So if that need is to be met, yes, reach out. I think, and I think it will encourage other people, telling your story and the people. And if you're a leader and you have other providers underneath you, other clinicians, and they can see that you're able to do it, you're walking what you're talking. Okay? You're talking the language of what you would tell your patients, what you would tell your team. If you're having an issue, you need to communicate it. That's how your needs will get met. That's how you will be safe. And that's how you will give somebody else hope. You don't know who you're touching by being able to carry that and to be able to express that. Because at the end of the day, you have to live with the decisions you make, and the fact that being a leader is hard. Nowadays in this society, it's very hard to lead. So having to deal with mental health, being a mom, being a pregnant, and being a leader, you have to give yourself, like you said, you have to give yourself grace. To be able to be there for your others and your baby, you need to be there for yourself.
Thank you. I have one question that's interesting. Besides women, are men affected by mood and anxiety disorders after becoming a parent, entering parenthood? How can we support men's mental health during this time?
I love that question. And yeah, there's research, really strong studies looking at paternal postpartum depression, depression and anxiety, and the non-birthing spouse or partner. And what I am familiar with, and Sinmi and Anita, please add on, but if a birthing person has postpartum depression and their partner is twice as likely to then also have postpartum depression or anxiety. So this is really important because if you think about it, you've got a mom who's clinically depressed, is interfering with her functioning, unable to take care of herself and probably the baby. And then you've got this now risk of dad or a partner who's depressed and anxious. It's like, who's supposed to take care of this baby? Because both individuals and the couple are struggling. So it's a really excellent question. There are specific resources for the partners for paternal postpartum depression and anxiety. Maternal Mental Health now will have some webinars, support groups, PSI, Postpartum Support International. So hopefully when you do your follow-up emails, Donnell and Lagaya, you'll share some of those resources and other local resources. I'm familiar with some. There's a group down in San Diego. I'm happy to share a link to their group. It's they've got a boot camps for dads where they talk about mental health and wellness in dads. So I think that there's a growing interest and realizing that partners are becoming equal partners. And what that's leading to is the shared responsibility. But what results in shared responsibility is shared stress. It's shared sleep deprivation. It's shared all the things that we've been talking about. So it's no wonder that they're going to also be at this.
I agree. And there's support groups. There's a lot of good support groups. A lot of facilities that I know of in SPA6 or around where I work provide different groups. And also, just to mention, just the situational stressors for the partner. The change of the relationship, the change of the role, the new responsibilities, those affect the partner, with if there's complications with mental health, along with just the day-to-day stressors. Can be a lot for someone who was used to a certain way and now just adjusting to the mother and the child. So I look at it from a whole perspective.
The whole family issue. Yeah, I know my husband was instrumental in my recovery, and he did not luckily come down with depression or anxiety, but it was to his credit because he was doing a lot of work because I was unable to do everything at a certain point for a few months. So I can definitely see how men can also develop those symptoms. Well, thank you. those are all of the questions that we have. I want to invite everybody to, if you have any questions that occur to you after this webinar, please do send them. I think you have Donnell's email, so please feel free to send her any questions and we will do our best to get them answered. We will also be pooling our resources and putting together a resource list that we will be sending out to everybody who signed up for this webinar afterwards. And I just want to remind everybody too that NAMI.org has resources and advice. If you go to NAMI.org and you just put in, search for maternal mental health, there is a whole page and then some on different resources and definitions and treatments and lots of information there too. And then the four of us will be sharing whatever we have with you. So it is 7:30, so I feel like we definitely filled our time. I hope this was of value to everybody that joined. It was definitely of value to me. And I want to thank our panelists again, Anita, Burdette, Dr. Accortt, and Dr. Bamgbose for joining us this evening. And just thank you so much for all of your knowledge and for taking this time. I know you're all busy women, and we just really appreciate you taking the time to do this webinar. So with that, is there any final comments or anything you guys would like to add? Or Donnell, anything you want to add?
No, just piggybacking off of what you said. Thank you so much. It's just to come into this space and from my own personal struggles, a lot of times you feel like, what's wrong with me? Something's wrong with me. And just to know that there's a whole community of us that can pull together. And I'm a big believer in sharing your story. And I know that's not comfortable for everyone, but what ends up opening up for people when you allow yourself to be vulnerable in that way is that they then begin speaking up and seeking the help that maybe they weren't doing before. So just thank you to all of you again for your knowledge and time being here tonight.
Thank you. All right. I think that concludes our maternal mental health webinar for this evening. Thank you again to the panel. Thank you to everybody who attended. You are just as important as our panel, helping spread the word from what you've heard here tonight. So again, we'll be sending out resources and sort of an after email to everybody. So look out for that. And if you have any questions that occur to you after, please feel free to send them Donnell's way, and we will do our best to get them answered. So with that, I just wish everybody a good evening. And I guess that's it from us here. So have a great evening, and we'll see you soon.
Thank you. Good night, everybody.
Thank
Bye.
you. Good night, all. Thanks for having me.
Bye.
Bye.